Okay, now we are live on YouTube. Yes, yes, Dr. Neminathan.
Mm. How is the weather in India?
It's a rainy weather, ma'am.
Oh, rainy. I see. So is it the dengue season when it's raining?
It is about to begin. At some places, maybe it has started, but it is in our part of the country. Yeah, we are
Mm.
awaiting. Like it will be soon.
Oh, so this is just in time.
Yes,
This
absolutely.
training. Yeah, yeah. Okay, that's good. Yeah.
Uh, we are in southern part of India, madam. So
Uh-huh.
we receive monsoon little earlier. By June 1st, we receive monsoon in Kerala, and
Uh,
our monsoon starts earlier. Then gradually it goes to Mumbai, then to Ahmedabad, to Chetan's
mm,
place.
mm,
Dr. Kaya Ghosh is northeastern part, so she'll be receiving monsoon little later.
mm.
No,
Then to also,
we are the eastern part. We are having a heavy monsoon for the last 1 month. So
oh,
all the so flu, dengue, all have started. A few
okay.
cases
Oh,
of
wow.
malaria. Okay.
So now
So,
we have a in
hmm,
South India, we have a combo of dengue, scrub, lepto, all those things.
I see. Oh, how do you make diagnosis then?
Mostly clinical, and we have support evidence of laboratory.
I see.
So,
Do you have, are you able to do your point of care NS1 antigen?
we do, madam. We do by ELISA method, not by CART test.
What is that? What test?
We don't do a CART test, which is a non-sensitive test, not recommended by Government of India. We do by ELISA method.
ELISA. But
Yeah.
ELISA takes time, you see.
Yeah,
So
yeah.
the NS1 actually is quite sensitive. The point
Yes,
of
yes. Ma'am,
yeah.
it depends. If we are in the center, usually we do the card test also. In where
Mm,
a very resource poor, limited setting, card tests have been used, and I think it is reasonably good sensitivity and specificity. But
yeah.
yes, of course, ELISA will be the best to have, but it takes time. But you can keep
Mm,
it in OPD also, take point of care test, and we can
mm.
just check it out on the OPD also.
Yeah. I mean,
So in the dengue season, I used to keep the kits ready. I was
yeah.
doing in my OPD and was checking whether it is positive or
Yeah.
not.
I think that's what needs to be done because without the test, it's really hard to know whether it's dengue or not dengue, and the opportunity for confirming the diagnosis in the early febrile phase is best in the first 1 or 2 days of the infection of the fever. So, and if you know that this is dengue, then you're more prepared for in my country, we already kind of like decentralized the use of point of care dengue, point of care testing, which is the includes the NS1 antigen, IgG, and IgM. But of course, both IgG, IgM, the
International speaker को
interpretation
काम
is a lot
link
more
भेजा है।
tricky. Yeah.
आ जाओ ना, आ जाओ।
Mm.
International speaker वो
Good evening, Dr. Lucy. Good evening.
Yes. Oh,
Uh,
Dr. Bashkas, nice to
So
see
nice
you
to
again.
see.
good evening,
Yeah,
Bhaskar
yeah,
Sanai.
Nice to have you.
Good evening, Bhaskar Sanai.
Good evening. Good evening.
Good evening.
yeah.
Thank
Good,
you,
good to see you.
the Neminathan, for arranging and organizing
Thank
Such
you,
a
sir.
wonderful speaker. Thank
Thank
you,
you.
madam, for joining, taking out your time and joining. It's
No problem.
yeah.
It
Thank
is my pleasure. Yes.
we are honored.
You are on the go, Dr. Bhaskar,
Yes, yes.
from one place to another.
There was one more one hospital inauguration. They called me as a chief guest. So
Very well. Good, good.
when the PICU was to be inaugurated, one
Mm.
Kindle Children Hospital. So they
Mm.
called me as a chief guest, and one MLA and ex-minister was there. And
Great.
I'm on the way back. So there I got delayed.
No
Mm.
problem. I think we are just 2 minutes away from the thing. Dr. Darul
So,
Rangnath is also there, past
Chetan,
chairperson. Welcome, sir.
what is the plan now?
Plan is just because this is the first program, you will welcome, right? Then I will introduce Neminathan sir and Dr. Lucy Lum ma'am. And then I will hand over to Dr. Neminathan and then he will invite Dr. Lucy ma'am, right?
Mm.
Good evening,
And then
Darul sir.
Dr. Neminathan will take
Good
a
evening,
question
good
answer
evening,
session.
sir.
Yes, sir.
Everyone.
Good evening.
Good evening,
Sir,
everyone,
Darul
sir.
sir, good evening, sir.
Good evening, very
Good
good
evening.
evening. All the best. A new program. Come on.
Yes.
Mm.
Yes, sir.
I think it's 4 o'clock and we should start.
Mhm.
Good afternoon, one and all.
Yeah, good afternoon, Dr.
Good
Nandi ma'am.
afternoon.
Good afternoon.
Good afternoon, madam.
Good afternoon, sir.
Madam, good evening, madam.
Good evening, Naimi.
Mhm.
Okay, so good evening, friends. And I am Dr. Chetan Trivedi, Honorary Secretary, Pediatric Infectious Disease Academy. It's one of the vibrant chapter of IIP, that is Infectious Disease chapter of IIP. And herewith we are beginning a new discussion and new webinar series. As we all know that we have one which is running successfully over almost last 17 months. That is a Super 11 series where we discuss the different cases with one moderator and four panelists. And now we have another series which is ID clinical case series where an expert of ID expert who is presenting a case and another ID expert is trying to decode that. That's the second series which is already going on. And now this is what we are going to go beyond the boundaries, and that we are going away out of the country, and we are trying to have the insights and the idea of how the best the infectious diseases have been managed in the other part of the world also. So we are going global pediatric infectious disease chapter. So this time we all know that this we are going to almost entering the dengue season in our country, maybe phase wise in different part of our country. So we thought let's have the first session on dengue, and for that we tried to catch hold of one of the very like perfectly proper person for this dengue management. That's Dr. Lucy Lam. She's from Malaysia, And we know that she was a WHO contributor for our 2009 dengue guidelines, particularly the classification which has been changed from 2009. So we are happy to have Dr. Lucilum, and for that we are thankful to Dr. Neminathan, who is from Coimbatore. He's we know that he's a executive board member of Pediatric Infectious Disease chapter, as well as he's been IMA vice president for the Tamil Nadu, and he's been very active member of Infectious chapter. So today we are going to talk about something on dengue, particularly outpatient department wise. So I'll first request Chairperson Dr. Bhaskar Shenoy, who has just set the this particular webinar to begin with. So we request Dr. Bhaskar Shenoy to welcome everyone. Thank you.
Thank you, Dr. Chetan, for that wonderful words. Welcome all the members and the guests for today's meeting. In fact, it is a new initiative that we have started from this year, as Chetan told. We are taking inputs and ideas from experts from other countries. So that is our idea. And let us improve the care of the children in our country by taking ideas and science and practice guidelines from other people who are experts in that field. And as Chetan rightly told, this is the season now. We are starting with the dengue. We have started seeing few cases, and within a few days it is likely to increase. That's what I expect. And this is the right time, that right person at the right topic and the right subject she is going to speak. I am very thankful to Dr. Lucy, and I was very fortunate to be with her in the dengue conclave in Manila, and her inputs and the ideas were super. So with that in mind, I welcome you, ma'am. Thank you for taking out time to come to our webinar and guiding us with the ideas about the management of dengue. Thank you, Neminathan, for organizing this particular wonderful webinar and being a coordinator for this. And thank you all the respected members and respected past president, Dr. Daruru Ranganatha, and past secretary Kea, and all the esteemed members for joining today's webinar. Thank you so much. Thank you.
Thank you, Dr. Bhaskar. Now I'll request Dr. Neminathan, who has coordinated the whole this webinar first episode, to go ahead, introduce Dr. Lucy ma'am formally, and then start the proceedings. Thank you.
Thank you, Dr. Bhaskar sir, Chairman of PIDA, and Dr. Chetan Trivedi sir, the Secretary of PIDA, and a sincere thanks to all the senior leaders, Dr. Darura sir, incoming Chairman, Dr. Sanjay Gorpade, Dr. Ashwant, and other senior leaders of IAP. Friends, we are extremely happy that this is the first international speaker forum seminar that's going to be held by PIDA chapter. And I'm also really happy that Dr. Bhaskar Chetan has given me an opportunity to be the opening batsman. Friends, today we have a close friend of mine, a pediatrician from Malaysia, Dr. Lucy. She has got vast experience in the field of pediatrics, more than 30 years. And her experience were mainly in the field of infectious disease, particularly in dengue. Friends, she has been an advisor to the WHO for the management of dengue in resource poor setting, because I've been traveling with her for nearly more than 20 years, and we have seen incidents where we can save children's life by using coconut water. Those were the days where nothing, even IV fluids was not there. Early recognition and giving them hydration with what is available in that particular country in very limited resources. So the mortality, which was very high, has been brought down to significantly low in many parts of the countries, particularly in and around Malaysia, Vietnam, Thailand, all those areas. It has been brought down to less than 0.5%. That's a great achievement. And I like to thank Lucy, who was part of this achieving this great milestone. Friends, you will all agree with me. Dengue has got a severe burden. Nearly around 5% of the global population are affected with dengue infection. Fortunately, 75% of them are asymptomatic. They do not develop the disease. Only 25% of this 5% of the whole global is only having symptomatic dengue. And another fortunate thing is that among the 25% who are symptomatic, 75% do not get the disease. They have a very simple disease and they go to the doctor with a cough or a cold or a loss of appetite or a body pain or a skin rash or watery diarrhea. Neither the doctor nor the patient knows that they have got dengue. They'll become all right without any treatment. So only 25% of the symptomatic dengue develop symptoms and then they go into little higher form of presentation. That is, when you see a severe dengue in our society, for example, if Dr. Bhaskar Shenoy sees one case of a severe dengue in his hospital and ICU, that's only tip of the pyramid. Nearly around more than 200 children are there who have dengue but not come to the surface. For every severe dengue, there is 200 dengue in the society. So with that beginning, I like to once again welcome Dr. Lucy Lam. We'll focus on this ever-changing disease, because dengue, which was it keeps changing over the years, and the presentation to us, to our pediatricians clinic also is variable. Previously, we used to get dengue children who come in the afebrile period. Nowadays, day one, they sit on our head and ask us what is the diagnosis. The presentation is little early, so we need to keep ourselves updated with the knowledge, so that we need to, the ultimate aim of this program of PIDA is to reduce the population, reduce the mortality of dengue in children to practically zero. With that big aim, our PIDA is inviting Dr. Lucy Lam. Dr. Lucy, the platform is yours, please. At the
Thank you.
At the end, we'll be having question and answer session. Thank you. Thank you, please.
Just before that, I would just acknowledge the presence of the most respected Dr. Varinder Singh, sir, is a professor from Hamdard, the Institute of Medical Sciences, sir. Welcome, sir.
Thank
We
you,
are
Dr.
highly
Chetan.
obliged.
Sir,
We are highly
good
obliged.
evening,
My
sir.
pleasure. My pleasure.
Welcome, sir.
Okay.
Varinder sir, good evening.
Welcome,
Good
sir.
evening.
Welcome, sir. Welcome.
Okay, ma'am, please.
Yes, thank you. Thank you, everyone, and the organizing committee. I am really, really deeply honored to be invited and to share my experiences with managing dengue, and also to have such an esteemed audience with me today. So I think without further ado, we will start off. Can you see my slides?
Ma'am, please share.
I'm sharing. No, you're not sharing.
No,
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 not
ma'am.
sharing. Let me see. Share. Okay. I am here. So you can see the slides?
Yeah.
So
Yes,
I'll
ma'am.
switch to slideshow. All right. So is it okay? Can you
Yes,
see?
madam.
Yes, ma'am.
It's okay.
Please.
Yeah,
Slides are
okay.
visible. Your voice is clear.
Yeah, so once again, I'd like to thank the organizing committee for giving me this platform to share my experiences in managing dengue in children. And for this episode, I think it's really important to do our outpatient management well. Okay, so the lecture contents, I'm just going to cover the clinical cause of dengue, the diagnosis, evaluation, because there is a wide spectrum of the disease, so we can't treat every child, every patient as if they have severe dengue, because some do not have. So we will go into what those are, and then we'll talk about management of dengue at the front line. I will not cover the dengue case classification and severe dengue because we don't have the time for that. So the objectives are to understand the spectrum of clinical dengue infection, evolving clinical presentation. If they come to you on day 1 and they're fairly well, it doesn't mean that on day 3, day 4, they're going to remain well. So it evolves. The picture is really dynamic. So the patient goes through different phases of the disease. So I'll try and define those phases as well. And very, very important is to appreciate the timelines. Okay, without these timelines, we don't know how we are navigating the patient through. So we also, for this lecture, we need to understand warning signs, because they are the ones that will give us the kind of signal that the patient is transitioning from the febrile to the critical phases of the disease. So again, times have changed. In those days, children come in, present late when they are in shock, but nowadays they don't. They present fairly early in the febrile phase. But our problem is, do we recognize them? And if we do recognize them, what do we do? So our emphasis will be on early recognition and hence early diagnosis and early confirmation. And this gives us the opportunity for optimal management. So we really need to, in 2025, we have to move forward with the time, and the technology is there, and I will share with you how we can get through this. All right. So like what Dr. Neminathan has mentioned, about every year in an endemic country like India, in Malaysia, about 5% of the population gets an infection with dengue. Vast majority are asymptomatic, only 25% are symptomatic. And as Dr. Neminathan mentioned, vast majority are just going to be mild, the non-severe dengue fever. Okay, and a small proportion, particularly in children, is a significant minority who develop severe dengue, and that's where the management becomes important. And most of them will survive, but a small percentage will not make it. So most of us start to recognize that a patient could have dengue when we see their platelet count, that the platelet count is low. But we need to remember that dengue is a very systemic disease. There are other features like headache, nausea, gastrointestinal symptoms like nausea, vomiting, myalgia, and changes occur in the bone marrow. Not just the full blood count, but actually in the bone marrow itself. And this occurs during the incubation period, even before the patient becomes symptomatic. Okay, so dengue is systemic disease and it's dynamic. It's not just a platelet count disease. So I will just deconstruct for you how the timelines will look like. And it covers approximately about 10 to 14 to 15 days of illness. So during the incubation period, once the child had been bitten by a mosquito that is infected with the dengue virus, the symptoms will not be immediate. There is a period of incubation, and that is about 3 to 5 days. All right, but during this time, the body is already trying to cope with the infection, and that produces the clinical pictures that we see later. All right, so not like we mentioned, not everyone will get fever, but 3 to 5 days after being bitten, you might see that if the patient is going to be symptomatic, he will have high fever. The fever is high. He also has headache, nausea, myalgia, and a rash. And this is when they start the onset of the disease. This because we would not know when the incubation period is. So this is the viremia period, and it coincides with the fever. Now, the febrile phase lasts minimum about 72 hours. Sometimes it can stretch to 4 days or 5 days, but it is around that 72 hours. Now, from the febrile phase, then after about 72 hours, 3rd to 4th day, then the patient, if he's going to develop severe dengue, will go into the critical phase. All right, the critical phase, what makes this phase critical is the plasma leakage. It occurs around the time where the temperature is coming down. So most patients will think, oh, my fever is down, so I should be getting better. But not if you have dengue and going into the critical phase. And at this point, the temperature may drop and the patients may start to have bleeding. Now, the important thing about this critical phase is to understand that it is a self-limiting situation. The plasma leakage is self-limiting and it lasts about 48 hours. Okay, so after the 48 hours, the plasma leakage is less severe and the patient then transits where the plasma leakage now resolves. So fluid that has been leaked out will need to be reabsorbed. All right. So generally, there is a reabsorption period, and by day 10, from the onset of fever, everything comes back to normal. Okay. So generally about day 10. So I'm going to deconstruct again. So at the top of this is the days of illness. All right. And the bars show more or less how the fever. So at the top is the days of fever, and then the parameters that are coming along. So the viremia and the temperature are very closely related. Like we said, after the incubation period, once the virus has reached a certain level, it gets into the circulation and the patient starts to have high fever if he's going to be symptomatic. This fever lasts 72 hours, and at the end of this period, the viremia comes down. Okay, so the viremia comes down and the temperature also comes down. Now, at this point, this is when they're going to transition, okay, from the febrile to the critical phase. Now, during this phase, you know what? The viremia is no longer so high. And what clears the viremia are the immune system, the adaptive immune system, the IgM in a primary dengue infection or IgG. All right. So as the fever comes down, as the viremia goes down, the fever comes down, and the patient, if he's going to be critical, he goes into a subnormal temperature. So from a high fever coming down, defervescence, what we call the defervescent phase, and then the temperature goes below if they are in severe shock. And then at the end of the critical phase, there is another blip of fever. All right, much shorter duration, but there is a fever. All right, so that gives rise to a biphasic fever or a saddleback fever. So this is very characteristic of dengue if you follow them through. Right now, the laboratory changes. This is what we used to do without confirmation, lab confirmation. We had to use the full blood count. All right, so in those the like I mentioned earlier, the changes had already occurred in the bone marrow. What we are seeing in the peripheral blood in the circulation lags behind what are the changes in the bone marrow. All right, so in the bone marrow, what we see is that the virus tries to get into the cell. And once it's gotten into a cell, there is a shutdown. There is cytokine release from the neighboring cells to tell all the other colonies of hematopoiesis that, oh, there is an enemy in the vicinity. Shut down your machine. So it means don't produce any more new red cells. No, don't produce any more white cells. Don't produce any more platelets. So what we see in the peripheral blood film is lags behind what is in the bone marrow. So on day 1, on day 2, you start to see the white cells coming down now. These are the old white cells. No new cells coming out, therefore the population declines. All right. And then once the viremia goes down, is cleared, then the bone marrow starts being reactive again and starts producing new white cells. All right. So these are the results of no new white cells coming up because at the bone marrow level, there is a maturation arrest. Now, the same story for the platelets. No, the megakaryocytes are not producing any more platelets. These are old platelets that are living out their lifespan, and therefore there is a gradual decline in the platelet count. But what happens during this transitional period from the febrile to the critical phase is that there is a sudden drop. Okay, it decreases slowly until it reaches 100, and then suddenly it drops, okay, to 50, and then to 20. That is when it is not the bone marrow's fault now. This part of it is the bone marrow not producing red cell, new platelets, but this is peripheral consumption because of the activation of the endothelium by the virus and interacting with the antibody, now we get activated endothelial cells that will then consume the platelets and keep it very low until the cytokines are, the lifespan of the cytokines are cleared. All right, so even when the white cells are improving, the platelets might remain low for an additional 24 hours before we see a platelet recovery. Okay, so that is the story with platelets. Now, with the hematocrit, because the red cells last 120 days compared to white cells and platelets, which have a lifespan of about 7 days, the red cell changes will not occur so they will be more stable. All right, but what happens during this transition period from febrile to the critical, the defervescent phase, is that there is a sharp rise in the hematocrit. And this is caused by the plasma leakage. All right, so the plasma leakage causes, because the plasma leaks out, the red cells remain behind in the capillaries, so the concentration of the red cells starts to rise. So this is part of the hemoconcentration. And if we don't manage these patients properly, then the patients may start bleeding, and then the hematocrit will come down. Of course, when we manage the patient, we recognize that the patient has got shock and resuscitate the patient with fluid, then the hematocrit will also come down. Okay? So you know that it will not stay up forever. It will go down, let's say for a child with a hematocrit baseline of 35, it may go up to 48, 50, 55, and then it comes down. All right, when it comes down, you don't know. Is it bleeding? Is it more your fluid? Right, so that is where the guidelines are very important. But that's another chapter altogether. And once they get into the recovery period, if they survive this critical period, there's a reabsorption of fluid, and the hematocrit, there's a hemodilution. So here there's a hemoconcentration, here is a hemodilution, and then they'll get rid of the extra fluid, and the kidneys will get rid of the extra fluid, and then the hematocrit returns to normal. Now, as far as clinicians are concerned, the important things revolve around fluid, the oral intake and the urine output, because our body needs water. All right, and if you have high fever and the outside temperature is high, and then you have vomiting or diarrhea, then that makes the child very quickly develop dehydration. Even if the patient does not have diarrhea or vomiting, just not eating, not drinking, and when they are having high fever, they will go into dehydration after 2 to 3 days. All right, so if we don't treat the dehydration, so this is where, as outpatient doctors, we need to recognize that dehydration. And then when they go into the capillary, develop the capillary permeability stage, which actually peaks at that time during the critical period, then they start off dehydration, and now they have capillary leakage. So you can see it's a double whammy, and it's no wonder that very quickly, especially in young children, they'll go develop hypovolemic shock. All right, and if we don't, again, miss the shock, don't manage it appropriately, then they start to have bleeding. So of course, once they start bleeding, the shock will get worse, the outcome will become very, very poor. All right, so this is how the thing pans out. Now, if they survive the critical period, then they go into a fluid reabsorption. So like we said, the critical period is self-limiting, lasts about 24 to 48 hours, and then they start to reabsorb the fluid. And we have to realize this as well, because we can't be giving IV fluid, because we will push them into fluid overload, and they could die from respiratory pulmonary edema. All right, so this comes like I've kind of deconstructed and put it all together for you. Hopefully you have a better idea of what the dengue looks like over time. Okay, organ impairment, okay, generally in relation to shock, but sometimes during the recovery period, the organ impairment continues, particularly the liver impairment. Okay, so now I'd like to talk a little bit more about the febrile phase. And usually we said it's about 72 hours, can be as short as 2 days, 7 days. The fever is very high. You may be able to modify it with antipyretics, but you cannot bring it down. And the other symptoms, apart from the high fever, is the anorexia. All right, the myalgia, headache, retroorbital pain, aches, rash. And during this phase, it is very difficult to differentiate dengue from other viral febrile illnesses like influenza, from leptospirosis. It's difficult. You can't tell because it's still too early. You do a full blood count on the first day or the second day of fever, it looks normal. It's going to look normal, but it doesn't mean that it's not dengue, like I showed you earlier in the previous slides, how the changes are going to evolve much later, right? So recognizing this phase is very important, and in 2025, we do have techniques of recognizing dengue. Now, so this phase of the disease is undifferentiated. You can't tell that this is dengue. The quality of life is already affected. The child's behavior has changed, his mood has changed, and even in young adults, they're not able to focus on their study, they can't take care of themselves. Nausea and vomiting are found to be more prominent in children. Now, the transitioning from the febrile to the critical phase generally is around about day 4 to day 7. So this is the time when the parents start to panic, fever is not coming down, my child is looking like this. So that's when they will present themselves to the hospital again. Sometimes it may come earlier or sometimes even late. But what is interesting is that the fever is not so high already. And that is why it is important to understand that the fever is coming down, but the child is not improving. So this is the only disease when the fever is coming down, the child is not improving. And they start to have warning signs. Okay, so these are the warning signs that tell you that maybe patient already in shock or going to develop shock. And we have to recognize these warning signs. It's the severe abdominal pain. It's not the pain that is little bit here, little bit there. No. It is very severe. And it's not only severe, it is persistent. Right? So it's severe, persistent abdominal pain because of the autoregulation in the splenic system. There is persistent vomiting, mucosal bleeding, the patient becomes really lethargic. Restlessness comes after lethargy. So by the time they're restless, they are really going to on the edge. All right, the liver becomes enlarged, and if you have an ultrasound, you may be able to see fluid accumulation, but usually you need an IV fluid to be given before you can detect clinical fluid accumulation. All right, so do familiarize yourself with the warning signs during the transitional phase from the febrile to the critical phase. Now, by this time, the white cell count is really low. The platelet count is very low and decreasing, and the hematocrit is rising. So at this phase, the disease has become differentiated. Okay, so earlier during the febrile phase is undifferentiated. By this time, platelets low, high hematocrit. There's only one disease that makes the picture like this, and that's dengue. Okay, and there is a risk that the patient will go into severe dengue. All right, especially when the platelets are low and the rising hematocrit. All right, so it is difficult to predict the cause during the febrile phase. So not only is it difficult to differentiate dengue from other viral diseases, even if you know it's dengue, which is possible nowadays, to make a diagnosis of dengue, confirmed diagnosis of dengue during the febrile phase. We won't know what happens when the patient goes into the afebrile phase, effervescent. Are they going to be severe, non-severe, or just dengue with warning signs? Obviously, those non-severe dengue will recover. Those with warning signs, most of them will recover. Some of them will go into severe dengue, and the severe dengue patients may recover. Most of them will recover. Some will die. Okay, so this is how the picture will evolve, and we do have an opportunity to improve the management, and it would have to be at the front line, because by this time, when you get into the 4 or 5 days of high fever, dehydration, there are too many things that are gone wrong with the child. Okay, so now I would like to talk a little bit more about abdominal pain, because this is what sometimes brings the patient to the hospital. What we mean by significant, to tell you that I have abdominal pain. And if you don't ask further, you think, okay, your abdominal pain, how many days? Oh, today, 1 day, and it's very severe. So you might think that this is surgical abdomen. All right, we have patients, thinking that the diagnosis is acute appendicitis, acute cholecystitis, but in actual fact, when they see the platelet count, they suddenly, oh my God, why is your platelet so low? Then you ask them, oh, did you have fever yesterday? Oh yes, fever yesterday, but today no fever. So for the patient, they cannot join the dots that yesterday I have fever, but today no fever. But I have pain. I'll just tell you that I have pain today. I won't, if we don't ask further that what was it? What were you like yesterday? Then you would not be able to join the dots. And you would think that this is a surgical abdomen until you see your platelet count, if you are meticulous. Okay. So what happens if this severe abdominal pain is associated with increased vascular permeability, and it tells you that the patient is either in shock or going into shock. Okay, so most common misdiagnoses are gastritis. Say, sure lah, you got abdominal pain, you haven't eaten for so many days already. So sure lah, you get pain. Or sometimes the gallbladder, if you have an ultrasound, you look at the gallbladder wall, it's thickened, then we say, oh, this is acute cholecystitis. Why? Your child has acute cholecystitis. With no stones, how to get acute cholecystitis? Okay. So leukopenia, by this time, like I mentioned, the clinical picture is very well differentiated. The white cells are dropping. In those days, before we were able to make a lab confirmation of dengue, we always look at the white cell count. If the white cell count drops below 4,000, we say, tomorrow your white cell, your platelets are going to drop below 100,000. All right. So it's a good indicator that the patient could have dengue. Now, a rapid decrease in platelet count and a rising hematocrit trend is definitely dengue. All right. There's no other disease that causes platelets to drop and hematocrit to rise. And this occurs around about the time of effervescence, temperature coming down. Okay, patient thinking that I'm better already because my fever is less. Then these changes will precede the changes before they go into shock, and is an indication of increased vascular permeability. Okay, so now if you have been given the patient IV fluids during the first few days, during the febrile phase, then you may not see the change in the rising hematocrit. But it doesn't mean that there is no plasma leakage. It could be leaking, it's just that we are not looking for it. All right. Now, what happens during the critical phase is there is a sudden increase in vascular permeability, resulting in significant plasma leakage. And this, if very significant, will cause the patient to develop warning signs and the patient's condition getting worse. So at a time when the fever is coming down, the patient starts vomiting, have abdominal pain, and they may not be able to join the dots for themselves. All right. So how long does the plasma leakage last? We mentioned it's a self-limiting condition, no more than 48 hours. So shock occurs when there is a large volume of plasma that is lost through leakage. Now, not every patient will lose a lot, especially the young ones, the infants, the young children. They may, if they get a dengue shock, they lose quite a lot of plasma leakage because the capillaries are not so mature yet. Right? So before they go into shock, they have warning signs that by this time the temperature is subnormal already when shock occurs. And if you do the white cell count, you might even see leukocytosis. Okay, so that actually tells us that the patient is actually severe bleeding at this point. You don't see the leukopenia. It might be a high white cell count. Now, what would happen if the patient did not receive treatment is that they will die. When they die, in children, they go into shock very rapidly. By 6 hours of plasma leak, most of them are already in shock. And if they don't get treatment within 24 hours, right, they will die. Now, in adults, their plasma leak is not as severe as in children. And also the adults are more able to compensate, so they may not die in the first 24 hours. But if it's severe plasma leak, they may still die in the second 24 hours before they go into reabsorption, right? So I'm just going to go through with you a case study just to illustrate how it looks like. This is a 15-year-old female who presented to the doctor on day 1. Okay, she had high fever, so she went to the hospital to see the GP. She had muscle ache, headache, and very poor appetite. The temperature was high, the blood pressure was okay, the throat was not inflamed, other systems were normal, but the doctor said, I better do a full blood count. And the full blood count shows the hemoglobin was normal, the white cells 7.2, still okay, platelets 235. I don't know what you have, but it doesn't look like dengue. All right. So she sent her home, and she had continued to have fever, and she went to the same GP, and this time round, she had another blood count test done, and you can see that the white cells have gone down. Okay, 7.2 to 5.3. If you didn't do a day one, you would think that, oh, it's still okay, ma. 5.3 white cell count can be okay, ma. But if you see this trend, then you know. Okay. Now, if you also didn't do the day one platelet count, you see 151, still within borderline normal range. All right. So this doctor didn't see the trend, thought that, I better check your urine. Saw the bacteria, the urine ketones 3+. You have a urinary tract infection. All right. But the ketones are 3+. Right. So on the third day, she's still febrile, went to do the blood test again, and you can see now the trend. All right, very clearly, the white cells are continuing coming down, the platelets are coming down, the hematocrit is still quite stable, and she had a blood test done, and by day 4, after she went home, on day 4, she felt really unwell. Okay, this time she didn't go to the GP, she went to the hospital. Okay, she went to the hospital, and this was her full blood count. Okay, you can see suddenly the hematocrit goes up from 34 to 48, and the platelets go down, and the white cells continue to decrease. All right, so at this point, it is well differentiated. At the day 1, day 2, day 3, it is not so well differentiated. So the doctor said, oh, you have dengue, you have morning signs. Okay, we admit you for IV fluid. So you can see here, we mentioned, so with the IV fluids, you can see the hematocrit coming down with the IV fluid, right? But you look at the platelets and the white cells continue to drop. All right, your IV fluid is not going to change the cause of what has happened in the bone marrow. So day 5 continues to drop, and continues day 6, the white cells turn the corner, improving now, but you look at the platelets, continue dropping. All right, the hematocrit has improved and stabilized at day 7. All right, so the patient usually when the hematocrit stabilizes for 2 days, the platelets show the upcoming trend, will say, okay, you can go home now. All right, because then we follow them up 1 week later. Now, you can see that if I were to ask you what lab confirmation, when would you do? So you have opportunities. When was the disease undifferentiated? It would be day 1 to day 3, because the white cells are still okay, the platelets. But if you have 1 day, every day, you can see the trend already. All right. So the question is, what test would you do on day 1 to day 3? What would it be the best test to do when you're seeing the patient on day 4, day 5, day 6? So we'll cover these questions later on. Now, I would like to talk a little bit about vascular leak, because this is the most serious complication in dengue and is the critical determinant of disease severity, is that hypovolemia. And this hypovolemia is secondary to increased systemic vascular permeability, and there is plasma leakage. So remember, when does it occur? It doesn't occur on day 1 for fever. Okay, it occurs at a time when, during the critical phase, when the temperature is coming down, when the platelets are dropping. Right, and if this vascular leak is severe, it leads to shock. Mild degrees of vascular leak may occur during the febrile phase. Usually, you need an ultrasound to detect it. Right, and again, another reminder that this is self-limiting condition, 24, 48 hours, and after that, they go into reabsorption. Okay, so what are the evidence of plasma leakage in dengue? So in the old days, we didn't have full blood count. We had to use the hematocrit centrifuge, and then we see how the hematocrit changes. Okay, this is a normal hematocrit of about 35, and when the child goes into plasma leak, the hematocrit goes up to about 60. So there is a rise in hematocrit. But of course, nowadays we can do the full blood count. Now, if you take an X-ray and this is an upright X-ray, you don't see the fluid, but the same patient, you turn her on the right lateral decubitus position, then you see, oh my gosh, there's a white collection of pleural effusion on the right side. Okay, so this is typically on the right side. And of course, if you give the IV fluid and go beyond that, then there is ascites. Okay, you can see that the face is quite swollen, puffy, and the child has got a big abdomen and large liver ascites. That makes her breathing really difficult. So this plasma leakage gets worse with our IV fluid. All right, so that's why we said that in the first 3 days, try to avoid giving IV. Okay, so these slides are shared with me from Professor Suchitra Nimanitya. She is a doctor working in Thailand, Queen Sirikit Hospital, and she's now maybe in her 90s. And the pediatricians of my age, we learned dengue management from our teacher, that is Professor Dr. Suchitra. All right, so this is just to remind me to tell you that my teacher, she is my teacher. Okay, now bleeding. Bleeding is mainly mucosal bleeding, epistaxis. These are quite common. Now, what is not so common is the severe bleeding. Okay, and the severe bleeding, this part, mucosal bleeding, is due to fragility, thrombocytopenia, but this severe bleeding is actually not related to severity of thrombocytopenia. And it's not also disseminated intravascular coagulation. But what we found in our studies is that it is related to the duration of shock. The longer they're in shock, the more likely they're going to bleed. All right. Or if we apply trauma, we are doing like, venipuncture to get a femoral vein or get one of the large veins and we missed it. Then they will bleed a lot. Or we give an IM injections on day 1, day 2. I want a fever and a strong antipyrectic and given IM injections, then they will start bleeding. Okay, occult bleeding is usually in the gastrointestinal tract, and because it's occult, it is difficult to recognize. But severe bleeding is life-threatening. Difficult to recognize, you don't see it in the initial phase, so it is life-threatening and causes refractory shock and often a terminal event. Okay, if we are not treating them quickly. Now, there are certain high-risk patients. Postpartum, mothers who deliver their babies at a time when they are going through the critical phase, and then the babies comes out, the pregnant mother, you quite often, that fever may precipitate a delivery, and then the platelets are low, and then now they have this placental surface that is raw and so they will bleed a lot. All right, could be adults with previous gastric or duodenal ulcers. They may not have bled, but now the platelets are low, they're going to bleed. All right. Now, the use of non-steroidal anti-inflammatory drugs are famous. Okay, they are famous for causing very severe bleeding. Patients who are on antiplatelets, usually these are not children, these are adults. Okay, who are on declaxane, on warfarin, on aspirin. Now they causes severe bleeding. If they have severe liver impairment as a result of cirrhosis, they also bleed. Okay, so it's good to understand your risk factors. So do all dengue patients enter the critical phase we mentioned earlier? Not only a small proportion will go into the critical phase. All right, so this is how we need to triage our patients. So for these patients who don't go into the critical phase, once the cause of the disease, once the fever subsides, they don't have severe plasma leakage, so they don't start to improve, they get better. All right, but if you look at the white cell count, it will still be low, and the thrombocytopenia will still be there, but maybe not as severe as in those patients with dengue shock. So what are the recovery signs of recovery? Is that the vascular permeability, like we mentioned, self-limiting, lasts 24, 48 hours, and after that, they will reabsorb. Okay, what are the clues that will reabsorb? Oh, the patient becomes more stable. They start to pass urine. They might have a fever, but remember, it's a biphasic fever, so don't worry, don't panic. Okay, They may have bradycardia, and in our light-skinned population, you can see the aisles are quite in sea of red, and it's actually quite pruritic, right? So it tells you that, oh, you're out of the danger. Or for us, when we see this rash, we will say, you're out of danger. But to the patient, they say, oh, you must give me something for my itchiness. Okay, it's okay. Yeah, at least you're not in danger anymore. So during this time, the fluid that is leaked out will have to be reabsorbed, and the kidneys will then do the diuresis, and then eventually the hematocrit stabilizes, the white cells start to improve. The thrombocytopenia, must remember, it lasts a little bit longer, another 24 hours longer. So you have to be patient. Don't worry. It will, as long as your patient is passing urine, the platelets will come out. Okay, so just to summarize the clinical problems during each phase, the febrile phase, okay, high fever, poor oral intake, okay, and because of the high fever, they develop dehydration. All right, so they are not drinking, and at high fever, some more, they have a dehydration. Within 24, 48 hours, if they go on 3 days, 4 days, they'll be really dehydrated. During the high fever, sometimes they may have hallucinations, develop febrile seizures. Now, the critical phase is when they start to have plasma leakage, they might go into shock, they might develop severe bleeding, organ impairment, and then the recovery phase is when it's the opposite. Fluid is coming back into the system again and into the circulation. They may develop hypervolemia, especially if they have been given a lot of IV fluid in the beginning. All right, so just to quickly run through how summarize the critical phase of the plasma leakage and the reabsorption phase. Okay, so now we are going to talk about evaluation of the patient. How do we evaluate? Because not every patient is severe. So our evaluation got to be very precise. All right. So I'm going to go through with you some steps. History taking, terribly important. All right. Examination, very important. How we do our investigations, and then we diagnose, and then we treat. All right. So what are the steps in history taking? The most important is you must get that date of onset of fever. Okay, without that, you don't know when that fever starts. All right. And from there, you want to know how many is the febrile phase. When are we reaching the 72 hours? Are we are we still in the 72 hours, or are we transitioning to the next phase, which could be the critical phase? All right. So we want to know their symptoms and severity. And very important, very simple questions. 3 simple golden questions. How much fluid have they been able to take? Not only the quantity, but also the type of fluid. What are they drinking? Okay. How much urine are they able to put out? So, of course, we cannot tell how many mils, but they say, the last 24 hours, how many times have been to the toilet, or how many diaper changes they have had, and the time of onset of the last voiding. Was it last night? Oh, since last night, no urine. So you know that this is very prolonged already. All right. So what activities have they been doing? Have they been in school? Have they stopped schooling? Have they been lying in bed, or are they looking at the handphone? Other fluid losses, very important, diarrhea, vomiting. All right, so that will add, if they're not drinking and now they have diarrhea, it will add to the dehydration. Okay, do they have warning signs? So the warning signs are not the only symptoms that you must catch. You must go through all these questions, because it will give you a fairly accurate picture of how you're going to manage the patient. Now, for other relevant questions, the neighborhood, because in Malaysia, dengue is notifiable, and there will be fogging the area. And in adult patients, if they are on medications, what traditional medicines, risk factors, like we mentioned earlier, whether infants, pregnancy, obesity, diabetes. Oh yes, this is the killer. All right, hypertension, gastric ulcers before. Now we have to also be a little bit open-minded about differential diagnosis, whether lepto, typhus, malaria, we still see in our country. So jungle trekking will kind of direct you towards that direction, or swimming in waterfalls. And seroconversion, HIV seroconversion can sometimes present with fever and thrombocytopenia. So when we do the examination, so the most important part is, of course, the mental hydration is from the 3 golden questions and the hemodynamic state. Okay, you want to look for warning signs, okay, whether they are bleeding anywhere, abdominal and tenderness, liver is enlarged or not, any fluid accumulation. But usually, generally, when they come in dry, you will not see fluid accumulation because they're too dry, right? But it's important to pay attention to their breathing, because if they're acidotic breathing, it could mean that they are already in shock. I don't know whether you do the tourniquet test, but if you are doing, if they're in shock, it might be negative. All right. So I'm going to pay attention, specific attention to the hemodynamic assessment. This is completely based on clinical. Okay, so now when we look at the circulation, we compartmentalize them into peripheral, that means the hands and the feet and the fingers, and the central circulation, which is the organ impairment. Okay, the organ perfusion. So it's skin perfusion versus organ perfusion. And then we need to consider the cardiac output and the respiratory, the lungs will compensate for any shortfall in the perfusion. So these are the 9 parameters when we look at conscious level, the capillary refill time, the color and the temperature of the extremities, peripheral pulse volume, the heart rate, the pulse pressure, which is a systolic pressure minus a diastolic pressure, the blood pressure, the breathing, and the urine output. All right. So so instead of having 9, I will cluster it into 4. Okay. So these capillary refill, extremities of the color and temperature of the extremities, the peripheral pulse volume, they represent the peripheral perfusion. These 3 parameters represent the cardiac output, and the conscious level represents the organ perfusion to the brain. All right, the urine output is perfusion to the kidneys, and the breathing rate is the respiratory compensation for tissue hypoxia. Okay, so as long as we understand what each of these mean, then we can get through the hemodynamic assessment. So in a stable child with a stable circulation, his capillary refill is less than 2 seconds, his extremities are warm and pink, and he's got a good radial pulse volume. His heart rate, pulse pressure, and of course these parameters, the cardiac parameters, have to be normalized for their age. All right, and then the conscious level is clear and lucid. They can talk to you, and they tells you that is a normal brain perfusion. The urine output is normal, so that tells us that there is enough fluid going into the body, and breathing is normal, which means that there's no need for the lungs to compensate for the respiratory acidosis. Now, what happens in compensated shock? Okay, so I'm going to show you the time. Again, here the x-axis is the timelines. These are the blood pressure and heart rate changes, and this is how it would look like when the patients go into plasma leakage, develop compensated shock. All right, you can see that the systolic pressure is more or less maintained. What changes is the diastolic pressure, a rising diastolic pressure. Okay, and that makes the pulse pressure narrow, so the pulse becomes weaker, and there is a tachycardia. So as long as the blood pressure is normal, because there is vasoconstriction, there is redistribution of blood to the vital organs and less to the skin, okay, the patient, now you can see that the skin is now cooler, cold, pale, prolonged capillary refill time, the lungs start to compensate, and at this point, the brain is still perfused because there is compensation, the blood pressure is still normal, so the patient is still talking to you and telling you stories, okay, your history. But the urine output is already decreased. All right, so this is how it will look like. A rising diastolic pressure, your peripheral pulses are already cold. So you really need to touch the patient to get that. So in a compensated shock phase, the perfusion, peripheral perfusion is already reduced. The cardiac output is already reduced, but the blood pressure, systolic blood pressure is still normal. There is tachycardia. Okay, the brain is still perfused. So the patient is still talking clearly and lucidly. But the urine output is already reduced, and there is already breathing faster, which tells you that there is tissue acidosis. So very subtle, but it's there. All right. And you need to train your nurses to be able to recognize these changes. So these changes are there. All have changed except the conscious level and the blood pressure, the systolic blood pressure. The diastolic pressure is already rising. Okay. Now, what happens if we miss this phase of compensated shock? Then very quickly, if the patient is not able to continue plasma leakage or bleeding, then he goes into hypotensive shock very rapidly now. Okay, everything drops, systolic, diastolic. All right, so then the pulses become feeble or completely disappear. Okay, and this is very sudden. Okay, and you may say, "Oh, so sudden, so sudden," but actually, it's not sudden. The child has been compensating. All right, the tachycardia is very severely tachycardic. He's very, very cold, extremities clammy, mottled, peripheral cyanosis, very prolonged capillary refill time. His breathing is very deep, very rapid, and his conscious level is no longer maintained. Okay, so you can see that it's a fairly rapid change. Oliguria and anemia, no more urine. Okay, so this is absolutely the last stop. So what is the key change? Is that the change in mental state. So from previously talking to you, now he becomes very restless, or very lethargic, or very confused, or they may suddenly have seizures, all right? And you may be like rushing into the CT scan to get the, no. Okay, or they may become very agitated, and then if you leave them alone, they are drowsy, and then when you go and measure the blood pressure, they're really pulling out their lungs. Okay, in young children, infants and young children, the parents usually will notice something. They'll say, the child looks at me but doesn't recognize me. Okay, or he doesn't make eye contact, or he looks at me but he doesn't recognize me. So something is wrong with my child. You better listen to these parents carefully. All right. Yet there are some children, and especially the young adults, who even when the blood pressure is low, they are still talking. Okay, it's very scary. Okay, they're still telling you stories that they want to go back to school. But you must know that this is a total cardiorespiratory collapse is imminent. All right, so this is really the last bastion. You don't want to wait for this to happen before you recognize shock. Okay, because this patient, they are really going on the edge of death, and you one wrong move and they just fall off the cliff. All right, so you really don't want to wait until this. So then, what do? If you don't want, you have to recognize what is the earliest. Okay, the earliest compensation is actually the kidney. The kidney is evolved to help us survive, that allows us to evolve from aquatic life to terrestrial life. Okay, so the kidneys are actually monitoring all the urine, all the volume already. Is whether you know it or you don't know it, doesn't matter. As long as you have functioning kidneys, they will do the monitoring for you. So you need, if you are wise, you look at the kidneys. That's why we said, one of the 3 simple golden questions is look at the urine. All right. It reflects you the kidney, the renal blood flow, and the kidneys will have the job of regulating your intravascular volume through secretion of DDAVP, ADH, all right, antidiuretic hormone. So even when the patient is in dehydration already, urine volume already reducing already, all right. In early shock, it will be reduced volume, all right. So the kidneys, this is the job of the kidneys. They are evolved to do this job. So whether we pay attention or not, that is our problem. All right. In severe shock, of course, there's no more urine. Okay. So now, what do we consider as an adequate urine output? Now, in the outpatient basis setting, if the patient drinks enough to pass urine 4 to 6 times a day, that's enough. Okay, 4 to 6 times. So every 4 to 6 hours, the patient has urine. That's good. Okay. Now, once they're in shock, you need more precise. So generally, we would say put in the catheter. I want to measure more accurately so that I don't overdo my IV fluid. All right. So at least 0.5 mils per kg of urine every hour. Okay. Now you can only rely on the urine as a reliable indicator, accurate indicator of your intravascular volume, only if there's one condition that you must make sure that it is there, and there is no diabetes, no hyperglycemia. Okay, because if you have diabetes, hyperglycemia, the blood sugar will undermine the function of the kidneys. So the patient will produce large amounts of urine, even when he's in shock. So you have to make sure that you control that glucose first. Okay? Understand? Okay, so in a hypotensive shock, okay, all the parameters have broken. All right. So now in the outpatient setting, we also teach something like this. You can teach your nurses to do. They do what we call a 5-in-1 maneuver. It's magic because you can detect the shock. All you need to do is to hold the patient's hand and evaluate the perfusion. And within 30 seconds, you can recognize the shock. And what do you see when you hold the hand? Okay, you look at the color of the fingers, the color of the skin, the capillary refill time. You feel the temperature. They're nice and warm or they're cold and clammy. All right. And then you feel the pulse volume, the radial pulse, and you feel the pulse rate. So very quickly, within 30 seconds, you already know whether the patient is in shock or he has a nice, good circulation. All right. So holding the patient's hands actually tells you about the perfusion and a little bit about the cardiac output. All right, because of the pulse pressure. So this is how it would look like when a patient in shock, even though the blood pressure is normal, but you can see that when you do the capillary refill, it takes a long time. Still, 6 seconds later, it still haven't come back the color. Okay, so this is very quickly how you would, by this time, you already know which day of fever the patient is in. So maybe this slide should come in later because we want to do more confirmation. Which day of fever the patient is in, what phase of disease, what is his hydration status based on the 3 golden questions, okay, the urine output, how much they're drinking and how much they're putting out. That's more reliable than any physical signs. And whether they have warning signs and what are the hemodynamic status based on the 9 parameters we have just discovered. And with this, you can then decide on a good medical plan for your patient. So now we're talking about management. Oh, before that, I think, we need to talk about testing, confirmation. Okay, in 2025, in our country, we have decentralized the use of point of care testing. Okay, so NS1 nowadays is available as a point of care test. The turnaround time is 15 to 20 minutes and easy to do. So all you need is a 1 drop of blood here, and 20 minutes later, it will tell you whether you're positive or negative for your dengue NS1. Okay, the only thing it doesn't differentiate is the serotypes, which is okay. It is the sensitivity can be very high for primary dengue infection. In the first 2 to 3 days, it's actually more than 90%. It's less sensitive for dengue 2 and secondary dengue infections, but it is very specific. So a positive dengue NS1 confirms the diagnosis. Okay, there is no false positive. It confirms, right? But it doesn't mean that you need to have an IV fluid. All right, you can actually do a confirmation on day 1 itself, on day 2 or day 3. But it doesn't mean an IV fluid. What it means is that you can do more proactive. Now you are in the driver's seat. You know what is going to happen. All right, on day 4, day 5, or day 6 of illness. Okay, so what we do proactive management in terms of counseling them for rehydration, follow up to severe disease. All right, and so dengue IgM and IgG are more difficult to interpret. So just to show you timelines, time is short. I have to move on fast. So when you have an IgM is a primary dengue infection, IgG comes in early but the problem is when it is a single positive test, that is when you are stuck. Okay, it's inconclusive. But if it is negative on early day 1 to day 4, but positive from day 5 onwards, then you have confirmed the dengue. But you need to demonstrate a negative earlier. in the disease. All right. So a negative on day 1, day 2, day 3 doesn't mean it is not dengue. It might become positive on day 5 because about 80% of the patients will be positive by day 5 and 99% by day 10. All right. But the problem is dengue IgM lasts at least 90 days. So a single positive does not confirm the disease. All right. So sometimes you have to send for ELISA. All right, which I think is what you all are doing. Okay. All right. Now, now we talk about management. So very quickly, we'll go through management. So we we talked about the patients who can be sent home. Before you're sending them home, you have to make sure that they fulfill all the following criteria. They're drinking enough fluid, passing urine 4 to 6 times. They don't have warning signs. And if you're doing the hematocrit, they're stable. They should have a stable hemodynamic status. And for adults, they don't have any coexisting condition. And the bottom line is these children are able to drink enough, to pee enough. Right? Before you send them home, it would be ideal to have a lab confirmation. And if you're doing the lab test, you might as well get a baseline hematocrit. Because once you have a positive dengue NS1, you know this is dengue, then you can give them advice. You can actually educate them on what will happen on day 4. When the fever calms down, you may think that you're getting better, but if you have vomiting and blah, 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 you need to come to the hospital as soon as possible. That is very important. All right. Then if you can monitor them daily to see whether they progress. All right. Okay. Now, number 3 is the anticipatory guidance before sending them home. So it is tell them what they need to do how to take care of themselves at home. So number 1 is bed rest. Okay. We used to say encourage oral fluid intake. So oral fluid is very important. And then these are the 3 things that you need to do. They are in pain, their muscle in pain. We don't want to give them too strong analgesics, just rest. Okay, you don't need to go to work. Okay, but instead of just encouraging oral intake, now we say you have to prescribe more precisely how much fluid they drink and what type of fluid they should be drinking. All right, so we'll go through this. So what is adequate? It's about 6 to 8 glasses of fluid for adults and children. And the question is, how do you achieve that? Especially when they have so much nausea and vomiting. So when we do prescription, we tell them what type of fluid. It is some nutrition, not plain water. Okay, because if they drink plain water, their sodium will drop, their potassium will drop. Okay, they can drink milk, they can drink coconut juice, they can get fruit juice, but be very careful with this commercial drinks. Oral rehydration, barley water, rice water, soups, that's fine. Okay, but be very careful with commercial drinks because the sugar is very high. Okay, they are just basically water, sugar, coloring, right? Whereas coconut water actually is very good. Okay, it's got less sugar, half of the amount of sugar, and more electrolytes. And so oral rehydration has been studied before and is found to reduce hospitalizations. All right. Okay. So just how do we get these children or adults to drink? Because they have so much nausea, so do not force the fluid down. Okay. If you force it, then they will vomit. Okay, so once they vomit, they lose confidence. They dare not drink. All right, so we divide it. So that's why the prescription is important. So like we said that since we have, let's say, if we divide the day into 6 hours from 6 a.m. to 12 noon, and then 12 noon to 6 p.m. Over these 6 hours, they drink 3 glasses of water. It means that every 2 hours, they need to drink 1 cup. Every 2 hours, 1 cup. So every hour is half a cup. Every half an hour is 1/4 of a cup. And then if you break it down, it's actually 2 meals per minute. So they don't need to drink even half a cup if they cannot. Just drink 2 meals. Just sip the water down every minute. So small amounts, do it slowly, mindfully. Don't force. Okay, but they have to do it frequently. Very important is to document so that we know how much they drink. All right. So similarly in children, same technique, but smaller cups, again, you have to document. All right, so this is the child that we were using a syringe and getting the father to syringe it down, and they document. How do they document? Okay, one stroke is one syringe. Okay, one stroke, one syringe. So we know until the child passes urine. Okay, when do we know that? They are well hydrated. Okay, so this is intense oral rehydration. Similarly, we can get the child to do it himself. An older child, you give them the syringe, they love it. Okay, instead of drinking from the cup, they say, I want the syringe. Okay, let them drink. So teach them how to get the water out, and the parents will then document how much drink. So with this, you don't really need an IV drip because the child is passing urine. You see that he's got fluid, water, and fruit juice. So he's getting his electrolytes. All right. So the third thing about management is fever. Fever management, very, very important, because that is what worries the parents the most. Okay, but you have to be very careful. You have to be very upfront with them that if you are using too much paracetamol, you will go into poisoning. Okay, so we always limit it to no more than 4 times a day. Okay, 10 milligrams per kilogram per dose. Now, if the fever is still there, what do? Warm, tepid sponging. Okay, so we don't want to poison the liver. We know that the liver is one of the targets for the dengue virus. So if you know that this is dengue and you're still giving paracetamol, you're really asking for trouble. All right. So ibuprofen, we know that there is going to be thrombocytopenia, so don't give your ibuprofen, aspirin at all, even though they are very, very potent antipyretics and anti-analgesics. So this is a paper that you can go through with you that shows that giving paracetamol can cause is associated with severe dengue. All right, upper GI bleed. So there was an article on that, an editorial, and that said that it is really not only is it not useful, it can actually cause harm to the patient. All right. So now I want to summarize this now, that dengue is really dynamic. The viremic phase is high fever, characterized by high fever, nausea, and we don't manage them. They are at high risk of developing dehydration. And if they are drinking only plain water, they also will develop electrolyte imbalance. And if they are not eating, they will develop ketosis. And if they have comorbid conditions, you can imagine all the problems add up. Okay, and when they transit to the immune phase of the disease, they have the plasma leakage, the bleeding, the organ impairment. And during the clinical fluid or during the recovery period, they get into fluid overload. Okay, they can develop brain stress. So most of the time, we see patients when they are severe dengue. Okay, and we see plasma leak, we see organ impairment, but we don't realize that all the problems that haven't been managed during the febrile phase, the dehydration, the electrolyte balance, they're all coming forward, being carried forward at a time when there are so many other issues. All right, and if they have been dosing themselves with paracetamol, NSAIDs, then you can see that the whole picture is so stormy. Okay, it is so aggressive at this point. All right. So in order to have a zero dengue death, we must have a strategic approach to dengue case management, and it starts with the febrile phase. During the febrile phase, when this fever is high, is undifferentiated, we need to make a confirmation of the disease. Once you have confirmed the disease, then you can manage, do your risk assessment, okay? And be really careful with your medications. Consider early admission for those patients with comorbid so that they can stabilize their blood glucose. The high fever, be very careful with the antipyretics and avoid totally the non-steroidals. Use tepid sponging. We know that they are at risk of dehydration and electrolyte imbalance, so teach them how to drink, what to drink, and document it. And then teach them. They are going to transit to the critical phase where they might develop plasma leakage, so educate them on the warning signs. What will happen? Identify which hospital to go to. Okay, So for those who do not have developed warning signs, then you continue to review them for the intake output chart, because they may go into progress into severe disease slightly later. Okay, when they get into the critical phase, all these problems become even bigger. All right, so remember the 3 golden questions, all right, and the plasma leakage and the bleeding. Okay, all right, so I'm going to stop here now, and thank you for your attention, because I think that deserves another topic. So I'm so sorry we have gone over time a little bit.
Thank you, Dr. Lucilla.
Okay,
for
shall
your
I
briefing.
unshare the slides?
Yeah,
You
yeah,
can just stop sharing.
Stop sharing. Okay.
yeah.
Yes.
Okay. All right.
Thank you,
So,
Dr. Lucilla, for a very lucid and a very powerful message to all the pediatricians in India. From the PIDA side, we are extremely happy that you have delivered a lecture with a very simple to understand and in a basic way that even in resource poor settings, we can manage and bring down the mortality of dengue to practically zero. Thank you for your learned message. Is there any questions we'd like to take?
There is a question in the YouTube
Yeah.
about which antibiotic is safer than paracetamol for fever control, other than paracetamol.
yeah, I think tepid sponging. Water is very safe. When the house is on fire, you need water to cool down. All right. So cooling down the head and then keep changing the towel so that they can get the temperature down. Yeah. So it gives them something to do and it doesn't harm the patient. But it's not using cold water. It's warm water. Yeah. Otherwise the child will start to shiver if it is cold water. Yeah.
So the same continuation is asking, what if child is known case of febrile seizure? So they are worried about the fever to bring down by any cost. And that's
Yes.
why they're asking whether what more than paracetamol you can afford. Like many times we feel that paracetamol is as if it is not working at all because it's not bringing down temperature. But this is a concern of the parents also, in particular in the febrile children, febrile seizure patients.
Yes. So I think it's the water is still good. Hydration is very important because when they drink, they pass urine. That urine is very hot. So you get rid of a whole lot of heat from the body when the child passes urine. All right. So you need water inside and water outside.
I think, shall I add a point to that?
Yes.
Please.
Yeah. As far as WHO is concerned, the safest and the only antibiotic is paracetamol. And
Yeah.
the NSAIDs like ibuprofen, mefenamic acid, they've got antiplatelet action. So they will cause thrombocythemia. The child will bleed even in spite of a good platelet number. So that is not recommended. And mefenamic acid has got seizogenic potential. In a child with fever, if you give mefenamic acid by itself will produce seizures. So no role for meftal or mefenamic acid. So it's in the message is only paracetamol. That's the only message.
But it has to be careful. It is not like you can have it at 6 times a day because we have seen paracetamol poisoning in dengue. It's fairly unreported, but it is there. All right. So it would be best if they limit the paracetamol and bring the temperature down in the clinic itself and make sure that the child drinks so that he can pass urine. And I think coconut water is very good. Coconut water, it is hydration. It is a hydration, yeah, and it gives the child some energy.
So there's one more question, what is the reliability of immature platelet fraction as a predictor of platelet recovery? Your experience.
Yeah, I think the immature platelet fraction has been in fact, we worked on it previously, and it's a sign of the bone marrow recovering. All right, because immature when we are talking about mature platelets at a time when there is a maturation arrest, that all the platelets there are all old platelets and they're dying off. Okay, so once you see the immature platelets coming up, then we know that the bone marrow is recovering. But the problem is the platelet count remains low because there is a peripheral consumption. So it's the peripheral consumption now that is causing the thrombocytopenia. Initially, it is the bone marrow going into arrest, and then later on, once the antibodies are interacting with the virus and the endothelium is activated, then there is a consumption, increased consumption. So the new platelets, they don't survive so long. So shorten survival as well. Yeah. But it does tell you that, okay, it's coming up. It means that, you know, that you are clearing the virus, the bone marrow is improving, and there is hopefully, usually it precedes the recovery of the actual platelet count.
So any cutoff we take it, let's suppose I image a platelet fraction of more than 10 or something,
Okay.
10%.
I'm not so familiar with the actual platelet count because in our study, I think we didn't have, I didn't pay attention to the cutoff point.
Okay.
Sorry.
I think it is more than 10%, and if you can see, then you can predict that it is coming up.
Yeah.
Shall I add a
please.
point, sir? Shall I
Yes,
add a point?
please.
Yeah.
Yes, please.
Actually, from the marrow, from the megakaryocytes, budding takes place and the platelets come out. If the marrow is recovering marrow, will start budding soon, and you can have a larger size platelets. When you do a cell counter in a Coulter cell counter, we have a 3-part cell counter. What we see is only platelet count and MPV, mean platelet volume. Mean platelet volume is a better indicator for a practitioner who is practicing outside. Whereas for an immature platelet fraction, you must have a cell counter that is different. You must have a platelet fluid that is totally different. That's a costly and it cannot possible in a smaller centers. So in a smaller center with a cell counter, we can see MPV, that's mean platelet volume. If it is more than 6, it's good. It's good indicator that the marrow is recovering. So that's a good indicator for a practitioner in a periphery. An immature platelet fraction, as rightly told by you, it is more than 10 is a good sign.
Dr. Kishore is asking, Madam, in adult patient who is allergic to paracetamol, or maybe adolescent patient allergic to paracetamol, can we give nimesulide in adult patient? Is asking.
Give what?
Nimesulide.
It's allergic to paracetamol. Can we give nimesulide?
I don't know. I have no experience with that. I'm
I
sorry.
think we should avoid that. Nimesulide, it is.
What
Dr.
is it?
Bhaskar?
What is that drug? Is
Yeah.
it an anti-platelet drug?
Yeah.
Dr. Bhaskar.
Yeah, all the antipyretics
Nimesulide.
other than paracetamol you should avoid. The best
Yeah.
thing I do in such cases is a tepid sponging.
Tepid
The,
sponging,
that is the
right.
best way that we can do it. And even
Yeah.
people use IV paracetamol. That is one more thing which is distressing, because some children with the IV paracetamol, they have gone into shock, and especially dengue when is about to go into shock, if you give IV paracetamol, the shock may get aggravated. So that is one more thing that we should be very careful in cases of giving IV paracetamol in these children with dengue.
Yeah. Shall I add a point, sir?
Yes,
So
please.
most of the time, the allergy to paracetamol is because of the ingredients, coloring agents. So what you can do is the patient is allergic to a syrup paracetamol that contains a coloring agent, or so it's a pure paracetamol allergy anaphylaxis is very rare. So you can use suppository instead of a syrup. You can, that's an easy alternative. And as rightly told, in nimesulide, there is an acute kidney injury. So it should never be used in dengue.
Right. And there's a question that any role of platelet transfusion in thrombocytopenia induced by the dengue. So I think there is no role whatsoever, but ma'am, can you just...
Yeah, I think we have stopped platelet transfusion about 30 years ago. 30 years ago. For 30 years, we haven't used. So, and the reason we stopped giving platelet transfusion was because of one patient. Just one patient, because 30 years ago, we were doing platelet transfusion for dengue patients. Until we met one patient, she was about 4 or 5 years old. She had an anterior mediastinal mass, so she couldn't sleep. She had to lean forward, and we thought that she had a T-cell, lymphoma. And as part of the workup for T-cell lymphoma, we would do HIV testing. And she was HIV positive. Right? And then when we checked the parents, both the parents were HIV negative. So now you have a 4-year-old child who is HIV positive with parents who are negative. All right. So we went back into the history. She had dengue a year ago. And during that time, everybody,
That's
not
so dear.
giving just 1 unit of platelet, but 3 to 4 units of platelets. You don't know which for. Nobody screened in those days. Nobody, it was not like a routine screening. So this child developed. So when I saw, I said, oh my gosh, I better stop now. Now I better stop it. I'm not going to give any more platelets. And that was how we stopped all these platelet transfusion. And then we wrote our paper. I think it was published in the early 20 turn of the millennium, 2003. The question was preventive transfusion. Is it necessary? So because we stopped, we were able to. So since that incident, we never used. We stopped using. And what happened was after the paper was published, the Singaporeans came. They said, oh, if you don't use that platelets, then what do you do? Then I said that they will recover. The platelet count will recover. Oh, really? So they went to look at that paper as well. They did their own adult series and they found the same thing, that, if you give them platelets, they're going to stay longer. They have more complications. So no need. So then was, that they published that paper after they had spoken to me. And I said, yeah, we should do it. And then we should do a randomized controlled trial. And so that was how we ended up with an RCT in dengue. I think that was about 10 years ago.
In the patient of dengue, there is a very low platelet. And if you want to go for some invasive procedure, what will you do?
I think
Suppose you want to go for central line.
Central line, you see, when I put in central lines for dengue, it is basically not to, it is for a dialysis, all right? They need a dialysis. They have gone into acute kidney injury, and I don't do a dialysis during the critical phase. I wait for them to recover, go into the reabsorption phase. I can take out all my fluid, and by that time, the jugular is actually looking at you. The jugular vein is really, poking out at you. At that time, you don't need an ultrasound. You can actually poke the needle. It's very safe at that point. But you can't put in a central line when they are hypovolemic, because if you miss it, then there is a big hole in the vein, and that is going to bleed to death. So generally, when I do a dialysis for dengue patients, it is after they have recovered. Everything is bulging, the veins are bulging, they're looking at you, wow, big, but there is bigger, and that is because they are reabsorption, but there is no urine output because the kidneys have calmed. Yeah.
But this thing is required when the patient is in shock. You don't find any peripheral veins. And sometimes you want to secure the central line. Because of that, people are trying for that central line because they have to, at least we should have one line. So that situation may arise when you are not having any peripheral lines and you want to go for central line just to keep one line patent. And at that time, platelet is very low. That's the situation may arise.
I normally don't do central lines when they are in shock. If they have one line, this is the only line. There is only one line, and we have rescue patients with just that one line. You have to tell everybody who takes care of a child, you have to take care of, this is her lifeline. This is her lifeline. So you got to take care of it. So don't touch it. That line is only for managing IV fluid, not for blood taking, not for anything else. Everything else is finger prick. Okay. Everything else is finger prick. We're sorry, we always tell them, you can survive with a finger prick. Okay, if you want to take MPC or blood gas, do the finger prick. That peripheral line is only for fluid. Well, actually, usually we do that until we put them to sleep. Sometimes we have to ventilate them, and then when they ventilate them, then we are more in control. Okay, but when they are awake, they're not going to allow you to lie still for you to put in a central line. Children, what do you expect? You have to actually intubate them, put them to sleep, hopefully they don't drop their blood pressure when you do that. And then, okay, now we use an ultrasound to look for the vein, and then we will do it more precisely. Yeah.
Thank you so much. I think we are almost done with the questions. And Dr. Sangeeta ma'am wants to say something.
Yeah, very good evening and thank you very much, Ambal, by your sharing so that I could come on board. Madam, excellent presentation, perfect
Thank you.
practical tips. I belong to Delhi and every year we see dengue. And so we have been seeing it since 1980s. There were two, three very important messages. One is the coconut water works. And I am in a hospital where we drain the urban slums and they used to buy injectable paracetamol, which I have completely stopped. So, and then with the advent of the shock management, your platelet dependence on the platelets have also gone down. Like you said, you just have to wait and watch. See, earlier we used to have this issue of management of these management of shock itself. So that used to be the issue. And of course, like you very well said, when house is on fire, you have to put water. So these are very important tips which Madam has given, very practical and very scientific. Thank you very much, Dr. Lucy, as well as Dr. Malika. And once again, thank you to all our stalwarts of PIDA. Thank you so much.
Thank you very much.
Thank
Yeah,
you.
it was really nice. Yes.
I
Nice
think
summary.
Yeah.
we can
So,
conclude in a minute.
yeah, we have Dr. Vijay Evle, sir, if you want to comment upon.
Yeah.
Evle, sir, are you there?
Yeah, I mean, this is one of the most practical talk that I have listened to on dengue, and I really loved the message of how to hydrate a child orally. You divide 24 hours in 4 quarters, and then the way she put it, that 203 glasses every 2 hours, so one glass every hour, half a glass, a quarter glass, and then you literally make a child drink with a syringe. What a lovely message! I mean, and the beauty is she hardly had to touch on IV fluids. I mean, they managed. So you prevent, timely and optimum fluid therapy with oral fluids, and then
Yes.
with the need of IV, and there is no question of shock and central line and platelet transmission. Fantastic talk. I mean, it was very lucid and very clear. And thank you so much for those practical tips and messages. And I'm sure large number of pediatricians would benefit. And Chetan, you must share this recording of this talk to all the members of IAP. And let's move towards zero dengue death. And I'm sure this talk is going to help us. Thank you so much.
Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Yeah.
Thank you.
Dr. Bhaskar.
Thank you very much. Yeah, thank you very much, Dr. Lucy, for that
Thank you.
wonderful talk. We wish to have you again for some other
No
time.
problem. Yeah. Okay. Thank you. Have a nice evening.
Thank
Okay.
you.
Thank you.
Okay.
Thank you. Maybe in future we can have a sick management of institutionalized child, sick dengue, management of
Yeah,
sick
I
dengue.
think we should have case discussions, because the
Yeah.
case discussions are really, really quite important, because sometimes we think, oh yeah, I know it already, but when you are thrown the case, then okay, now how do we interpret those physical signs, and then what do we do? Yeah, I think that is very important, but today there is no time for that, but maybe future lessons, yeah, we could do that.
Dr. Daru, sir, you can just thank and give comments. Last final word from you, our past chairperson.
The most practical way of treating a dengue fever. Today, she has described it to the best. So, for the last 30 years, have been coming across with this, managing in PICU, and now in the OP also. So, the crystal clear recommendations should be implemented. That is my suggestion. Thank you, madam.
Thank you.
So at the end, I would like to thank Dr. Neminathan for this coordinating this. Thank you, Dr. Lucy, for the wonderful talk. Thank you all the experts for being there on the ice. Thank you so much, and see you maybe a third Friday every month. We'll be having one international speaker forum. Thank you so much. Thank you.
Thank you. Thank you. Thank you, everyone. Thank you, Dr. Lucy.
Bye.
Thank you,
Thank you,
Bhaskar. Thank you,
Navinathan.
Chetan. Thank